I am Dr. Monica Baskin, Professor of Preventive Medicine and Associate Director for Community Outreach and Engagement at the O'Neill Comprehensive Cancer Center. I will briefly talk about race and place matters in delivering high-quality cancer care. I have no disclosures at this time. First, race matters. As shown in this chart of cancer death rates by race and ethnicity, the overall cancer death rate is higher among non-Hispanic Blacks than for any other racial or ethnic group in our country. Second, as shown in this map, we see that cancer death rates are higher among individuals residing in the Midwest and Southern regions of the United States. And as we look further at place matters, we see that individuals who live in rural counties in the 12 states that make up the Appalachian region, with the exception of Maryland, have higher cancer mortality than their counterparts that live in non-Appalachian counties, as well as in urban areas across the United States. So now let's look at the intersection of race, place, and cancer mortality. This table looks at age-adjusted cancer mortality rates by rurality and region, looking at the overall United States as a whole, as well as the Appalachian region mentioned previously, and the Delta region, which includes a number of counties throughout the Midwest, as well as the Deep South, including Alabama, Arkansas, Louisiana, and Mississippi. Taken together, this table shows, with few exceptions in bold on the table, that individuals living in the Appalachian and Delta regions have higher cancer mortality rates for these select cancers than for those who live in other parts of the country. In addition, this table further shows the consistency in racial disparities in cancer mortality, with, generally speaking, Blacks having higher rates than their white counterparts. So there are likely to be a number of reasons to why we see these types of disparities. But one of the challenges to the access to high quality care is that of the number of hospitals that have closed in rural areas since 2010. This data shown and mapped on the left side suggests that the large number of closures have also occurred in the regions of the country where we see the highest cancer mortality. On the right, we're also seeing data that suggests that the COVID-19 pandemic has or will continue to lead to further challenges with overall healthcare access, with hospitals closing in rural areas at an alarming rate. Further challenges to high quality care among rural and African-American populations have been shown in the literature. One of those has to do with provider bias. So we know that racial biases of oncologists are associated with shorter patient encounters, less patient-centered and supportive care, greater patient difficulty remembering the contents of that patient and provider interaction, as well as less patient confidence in recommended treatments and greater perceived difficulty completing those treatments recommended by their oncologist. In addition, a study of researchers and clinicians associated with oncology clinical trials at 5 US cancer centers found that participants indicated that the recruitment interactions with potential minority participants were perceived as challenging. Potential minority participants were not perceived to be ideal study candidates. Negative perceptions of minority study participants led to providers withholding clinical trials opportunities for potential minority participants, and race was perceived as irrelevant when screening and recruiting potential minority participants for clinical trials. And then one other challenge that I will mention here, and that has to do with limited trust in providers and medical research. A poll that was that was given last fall shows that 70% of Black respondents believe that our healthcare system very often or somewhat often treats people unfairly based on their racial or ethnic background. That same poll also found that 54% of Black respondents believe that doctors do not provide the same level of quality care to Black and white patients. And they furthermore believe that the major reason for the disparities between Blacks and whites has to do with that disparity in treatment. Issues of trust and hesitancy are certainly steep both in historical as well as current issues related to denial of treatment, lack of informed consent, and or failure to recognize and or compensate contributions to biomedical research. But despite all of those challenges, there are multiple opportunities to improve access to high quality care among marginalized populations. For example, the Kaiser Family Foundation recently summarized a series of research studies indicating improvements as it relates to Medicaid expansion. Some of these relate to increased insurance coverage rates among cancer patients and survivors, increases in early stage cancer diagnosis rates, increased cancer screenings, increased rates of HPV vaccinations, reduced disparities in coverage by income and education, as well as decreased socioeconomic disparities in utilization of care and individual financial stability. Specific to rural areas, the expansion also met with greater improvements in access to care, including mental health, as well as rural hospitals experiencing particularly substantial improvements in financial performance. In addition to anti-bias training among providers, we also know that better education of marginalized groups about clinical trials is extremely important, including addressing common myths, as well as providing reasons for why their participation in trials is really important. At the same time, beginning in January of next year, the Clinical Treatment Act would allow for routine costs associated with clinical trials to be covered by Medicaid, an opportunity that was previously only for Medicare and private insured individuals. Other opportunities focus on building trust between patients, providers, and healthcare system. At my own cancer center, we do that by including bidirectional communications with our clinical providers, patients, and community members, as well as using lay navigation to help community members throughout their cancer journey. And lastly, I think this quote says it best. In a world still shaped by systemic racism, Black patients are more likely to trust and heed the advice of Black physicians. As such, we must do more to diversify the biomedical workforce. As shown from the data on the right, we still have a ways to go. With that, I thank you and I look forward to the panel discussion.